Right, I'm talking to David now. Hi David, thanks
Hello.
for coming
Yep.
along. You're doing a really interesting talk today on driving. Can you tell me a little bit more about this?
Well, in particular, this is not driving in general because I'm not a very good driver. This is driving in old age.
Yeah.
And I've concentrated almost exclusively on driving with dementia or cognitive impairment.
Yeah. So these are really difficult things as a GP to approach a patient about. Can you give us a bit of an idea of what we should be doing?
I think they're very difficult for a geriatrician as well. What's really important is to recognise that there is a conflict in our professional obligations here. The general practitioner or the specialist, usually their major and often exclusive concern is the patient with or without their family and relatives. In this particular context, of course, we've got an obligation to public health and public safety.
Yes.
And that obligation is made clear in the legal framework in which we act. Although I'm not a lawyer, and I'm certainly not talking today about the legalities of what we do. It is important to assess the safety of patients when driving. It's a very easy thing to avoid.
Yeah, I was going to say, I'm sure a lot of people do try and avoid it because it's very uncomfortable.
It's very uncomfortable, and I should acknowledge that it can be very damaging of the therapeutic relationship between the GP and their patient, and that's a long-term relationship. The relationship between the geriatrician and his or her patient is often not so long-term. And I think, and one of the things I will say today is that I think most geriatricians, although that may not apply to their employers, but most geriatricians are happy to help GPs in this difficult conversation. As are most of my psychogeriatrician colleagues, I'm sure. The assessment is usually triggered by a standard question that we should ask all older people with disability, irrespective of their cognitive status: do you drive? And just as we should ask, do you fall over?
Do you smoke?
Or do you have weight loss? Standard question should be, do you drive? And if a patient says yes, then we should just recognise that we need to take account of their disabilities, particularly their cognition. Driving for New Zealanders is very much of who they are, and it's easy to think about the stereotypical New Zealand bloke who's attached to his car, but some of the most difficult conversations I've had have not been with New Zealand blokes, they've been with Chinese women. Indeed, I had a patient on the ward this week who turned up and got a moderately advanced dementia. She took one look at me and said, "You stopped me driving." And that was more than a year ago. And so we shouldn't assume that it's only the New Zealand bloke that's going to find this conversation difficult. The really important bit of the assessment is the history. And it's not the history from the patient necessarily, it's from the history from significant others. Do you drive your husband around? Oh yes, what does your husband say about your driving? Or if the husband's there, how is your wife's driving? And he says, well, and a good question, if you've got family members with you, is, particularly if you've got the patient's children with you, do you let Grandad drive the grandchildren backwards and forwards to school or around the place? And if they said, no, I wouldn't do that, then that should certainly ring bells.
A red flag there, isn't it?
Of course, once you're concerned about driving, you take a history about driving accidents and speeding fines and that sort of thing. Patients often have explanations for bumps and scratches that may not be the true account. I had a patient 10 days ago in the clinic who told me it's because the things in the garage fell onto the car. What he didn't say, of course, he'd bumped into the shelves that made the things. And taking a careful history is the most important thing.
Absolutely.
I think our family doctors are quite good at picking up those signals. What they find difficult is the next bit of the conversation. I don't think you can drive properly.
Yeah.
Now, there are some quasi-objective tests we can do. We can do cognitive assessment tests and trail-making tests. They are not validated, but they may be helpful in pointing out to patients their deficits. If a patient can't give you a clear explanation of a stop sign or a speeding control sign, then it indicates to them that they are struggling.
That's right.
When we have the conversation, I think it's very important that we identify, I am now not talking to you as your doctor.
That's a good way to put it.
I have a responsibility to everybody else on the road to discuss with you your difficulty driving. That perhaps helps some patients and some doctors to get round this conversation. If we have concerns, however, we do have an absolute obligation to tell patients. And often the patients don't remember or don't want to hear and speak to their families. I always follow up that conversation with a formal letter. Not the letter that reviews the whole consultation, but a separate letter about the driving. And in bold print, you must not drive. And you're not insured if you've been told you haven't driven. And the letter always has a sentence saying you're entitled to a second opinion. Now, if it's a family doctor doing this, the second opinion may come from a geriatrician or a psychogeriatrician. For me, it's often a formal disabled driving assessment done by our occupational therapy colleagues. This is not the same as an AA driving test. This is something much more detailed and is much more expensive, $500 to $700. However, a surprising number of patients actually take that option. And if all your patients fail that option, then you're probably not being strict enough. Our occupational therapists feel confident to give advice about limited driving privileges. That is, only in daylight hours, not on motorways, only within so many kilometres of the home. I struggle with that as a concept. Either you're safe or you're not. And it's not safety when you're going well, it's safety if something unexpected happens.
Oh, David, it's a really interesting topic, and I think that key phrase, we shouldn't be afraid of doing this, and we have an obligation to do it, is really important. So thank you for talking to us today, and I hope you have an enjoyable afternoon.
Thank you.
Thank you.